Good day and very welcome to lesson 2, and in this lesson we are going to discuss the progress of labour. Now the progress of labour part on the partograph that you see here in front of you, there are certain principles that we're following when we record on this part of the partograph. And the first of all is that the partograph is being divided in a latent phase and an active phase. The latent phase is from the beginning of labour, of the first stage of labour, until the cervix is 5 centimeters dilated. Now here you see 4 centimeters in brackets here. It was always 4 centimeters, and then because of evidence that was available, it has been decided that to make the latent phase from the beginning of labour until the cervix is 5 centimeters dilated. Now when I say it has been decided, it has been decided by the World Health Organization and Department of Health in South Africa, etc. Now, some of the provinces in South Africa at this stage, Gauteng, for example, still works on the 4 centimeters dilatation for the latent phase of labour. We always said that the latent phase could be 8 hours, and that goes together with the 4 centimeters before it's prolonged. But now it has been decided that the latent phase is 12 hours. So if the latent phase is longer than 12 hours, it's prolonged. Then the active phase of labour, which is on this part of the graph, commences at 5 centimeters dilatation, or in the old language 4 centimeters dilatation, and the woman in the active phase of labour should dilate 1 centimeter per hour. Now, when we talk about the beginning of labour, we've said that the latent phase is from the beginning of labour until 5 centimeters dilated. Now, when is the beginning of labour? Is it when the contractions start, or is it when the cervix start dilating, or is it when the membrane ruptured, etc.? Now we say that the beginning of labour is when there are persistent painful contractions. Now the persistent is very important because we know that at the end of pregnancy, the Braxton Hicks contractions become painful and are often being confused with proper contractions, and the patient then goes in what we say false labor, because then usually the contractions start and then they disappear again. But when they are persistent, when they continue, when they become more rhythmic and regular, together with one of these signs, we say that the patient is in labor. So the persistent painful contractions together with cervical effacement and dilatation, or painful contractions together with ruptured membranes, or painful contractions together with a good show, or painful contractions together with more than one of these things, will then define the beginning of labor. Now, if we look at cervical dilatation, which we will come in just a little bit more detail just now, which is the enlargement of the cervical os. We record this on the partograph in this way. Here you see a vertical row of numbers from 1 to 10. That's the cervical dilatation in centimeters. So if the cervix is, for example, 6 centimeters dilated, we will record it against this 6 centimeters here on the partograph, and we do it by a cross. Now we see vertical blocks on the partograph, and we also see horizontal blocks on the partograph. Each block on the partograph represents an hour. So if the patient, for example, was 10 o'clock here and she was 6 centimeters dilated, that's where we will record it there. Then just a little bit more information about cervical dilatation so that one fully understands the effect of cervical dilatation on the progress of labor, if I can call it like that, on the partograph. Now, cervical dilatation means literally the cervix opens from a tightly closed cervix in the beginning of labor to a fully dilated cervix at the end of labor, where it's open big enough for the fetal head or the fetal presenting part to be born. Now, there are different aspects that has an influence on the dilatation of the cervix. The better the presenting part fits on the cervix, which we call application, the better, the more pressure is there on the cervix, which helps with the dilatation of the cervix. It also causes a reflex reaction. If there's pressure from the presenting part on the cervix, like when it's applied well, when it fits well on the cervix, we get the reflex reaction where more prostaglandins are being secreted that causes better contractions of the uterus, and the uterus contracts better, and that leads to the opening of the cervix. Now, another aspect of the cervix that goes with dilatation, and that's also very important for the progress of labor, is effacement. Effacement, there's not place on all partographs to record effacement. Some of the partographs, like the one that we are using here, has effacement on it, and some partographs not. Effacement means literally that the cervix has been taken up as part of the lower segment of the uterus. What happens in the beginning, end of pregnancy and beginning of labor, is that the cervix is long, it has an internal and an external os, and it's totally closed. Both these internal and external osses are closed. And then what happens is that this internal os starts opening, and then this part of the cervix is literally being taken up as part of the lower segment of the uterus, as you can see here. So in the process, the cervix gets shorter and thinner, and eventually it's paper thin. And that is what we call effacement of the cervix. Now, this happens in the primigravida. This usually happens before the dilatation of the cervix. So it starts happening here at the very end of pregnancy, beginning of labor. But in the multigravida, it often happens together with the dilatation of the cervix. Now, if we are back on the partograph, on the progress part of the partograph, we are now first at the latent phase, and we have, as we've said, latent phase is from the beginning of the first stage of labor till when the cervix is 5 centimeters dilated, and 12 hours is allowed for it. Now, during the latent phase of labor, we are supposed to do a vaginal examination 4-hourly to determine the progress of labor. And then when we look at the active phase of labor, as we've said, the active phase of labor is from 5 centimeters dilated and further. And here we should plot the progress of labor, preferably every 2 hours. So we should do our vaginal examination and determine the progress of labor every 2 hours. And as we've said, the cervix is supposed to dilate at 1 centimeter per hour. Now, on the active phase of labor, and this is also a common characteristic, if I can call it like that, of all partographs, we find the alert line and an action line. Now, as we've said, the patient is supposed to dilate at 1 centimeter per hour, and this alert line is from 5 centimeters being drawn through the partograph at 1 centimeter per hour, as you can see here, because remember we've said one of these blocks represent an hour. So this is the ideal time for the patient to dilate during the active phase of labor. If she dilates slower than 1 centimeter per hour, the dilatation will fall on this right side of the alert line, and that means that the labor is slow. and something should be done about it. If the woman is in a peripheral hospital or a clinic, she should be transferred to a hospital. If she's in a hospital, the doctor should be informed and she should be observed more frequently. It's now very important to try and decide what is the reason for this delay in labor. Then if we look at the action line in the South African partograph is being drawn 2 hours from the alert line. And this means that if the cervical dilatation falls on the right side of the action line, labor is seriously, the active phase of labor is seriously prolonged. And the two names of the two lines tell you exactly what it means. If the cervical dilatation crosses the alert line, we should be alert. But when it crosses the action line, action should be taken. So again, the patient should be referred to a hospital if she's not in a hospital already, or the doctor should be informed about the slow progress of labor, and action should be taken. Action is not necessarily a cesarean section. Action can be, for example, augmentation of labor, depending on what might be the cause for this slow labor. Now, just a small word on how do we transfer latent phase to the recording of the latent phase to the active phase of labor. So say, for example, this patient has arrived here in the labor ward and she was, say, for example, 4 centimeters dilated and in the latent phase of labor, and we have recorded it here on 4 centimeters. And now we have done a vaginal examination again, and she's now 7 centimeters dilated. So she's now in the active phase of labor. So we have to transfer this now to the active phase of the partograph. And we do it by just repeating the recordings that we have made here onto the active phase of labor. And we record this cervical dilatation in the active phase of labor where it crosses the alert line. So where the 7 centimeters crosses the alert line, that's where we will record it. And so now we know from here on the patient needs to dilate 1 centimeter per hour. If she was, for example, 6 centimeters dilated, we would have put the cross here on the 6 centimeters where it crosses the alert line. Not here where she enters the active phase, but where it crosses the alert line. Then on the progress part of the partograph, I think you have seen now that there are 2 aspects that needs to be recorded. One is the dilatation of the cervix, and the other one is the engagement of the presenting part of the fetus. Now, if in the case of a cephalic presentation, the definition of engagement, we say, is when the biparietal diameter, this part of the fetal head, goes into the labor. It passes through the plane of the pelvic inlet. That is what we call engagement. We measure it by doing an abdominal palpation, and then we determine how much of the fetal head is still above the pelvic inlet, and we measure it in fifths. So if the head is still above the pelvic inlet, we can still ballot the fetal head, it moves freely, then we say that the engagement is 0/5, or there's 5/5 still above the pelvic inlet. In this case, there's a little bit, 1/5 of the head has already been engaged, and then we say there are still 4/5 above the pelvic inlet, 3/5, 2/5, 1/5, and now 0/5 above the pelvic inlet. Now, usually in the primigravida, this engagement starts happening from 36 weeks of pregnancy onwards. In the multigravida, it can happen anytime from when the labor starts till the baby has been born, almost fully dilatation. Now on the partograph, back on the partograph, how do we record this engagement? Now we use this bottom 5 numbers of the cervical dilatation to record our engagement, and it's been recorded by a zero, a circle, and here we see, for example, this patient was 6 centimeters dilated, and there was 2/5 of the head above the pelvic brim, so our engagement that we record here is 2/5. On some of the parthographs, you can see here, one draws a circle, and then one can also in the circle draw the position of the fetal head. So if it's an occiput or posterior position, we will draw the occiput here on the posterior part of the circle, etc. Now, on the bottom part of the cervical dilatation part of the partograph is now here above this part, and then there are some other criteria of the progress of labor that we also need to record. Like, for example, the application of the presenting part on the cervix. Now, we have said previously, application means how well the cervix fits on the presenting part, or rather, how well the presenting part fits on the cervix. And we have said that the better the presenting part fits on the cervix, the more pressure is there on the cervix that causes this reflex reaction, better contractions, and that makes that dilatation also improves. We just record application as poor or good, a P for poor and G for good, or we can even write there P or good or poor. Then when we look at the descent of the presenting part, the station of the presenting part, that we will record here on this partograph. And the station or the descent of the presenting part literally means how far the fetal head or the presenting part of the fetus has descent into the pelvis. And we measure that according to the ischial spines that you can see here, that's on the pelvis, and one can, when you do a vaginal examination, normally easily feel these prominent spines. When the head, the lowest bony part of the head is level to these ischial spines, we say that the station is 0. When the bony part of the fetal head is above these spines, the station is -1, -2, -3, and when it's below the spines, we say it's +1, +2, +3. +3 means the head is literally on the perineum. Now, what is very important, what I'm saying here is that molding and caput succedaneum can give us a false indication or a false impression of the descent of the fetal head. Now, we all know, and we will come to the caput succedaneum now, it's a swelling of the fetal head because of pressure, the pressure of the fetal head on the cervix. Now, swelling might make that this, and specifically in prolonged labor, we often get that there is quite a lot of caput succedaneum. So we might feel some fetal head here, say for example +1, but in the meanwhile we are only feeling swelling because the bony part of the fetal head might only, for example, be at -1. So we must make 100% sure that what we feel is bony part of the fetal head and not swelling. Then when we talk about the presenting part, as such, it also plays a role in the progress of labor, as I will indicate to you now. Now, the presenting part is being defined as the part of the fetal head or the fetus that lies over the uterine os during labor. So that's the part that's going to be born first. We have a vertex presentation, or we can get a brow presentation, face presentation, breech presentation, or a transverse presentation. Now, transverse presentations can't be born normally, so this is already an indication for a cesarean section, and there will be no progress of labor. But the vertex presentation is the presentation where we get the best progress of labor, if I can call it like that, under normal circumstances, because it's usually the smallest part of the head that presents, while in these cases there's a much bigger diameter of the fetal head that presents. That will obviously take much longer to get through the pelvis than in the case of a normal size vertex presentation. A vertex presentation is also the fetal head is nice and hard, and if there's good application of this fetal hard head on the cervix, then we get good contractions, as we've said earlier, and labor can progress better. In the case of a breech presentation, for example, the breech is soft and irregular and doesn't fit well on the cervix, and therefore application is not good and labor might be prolonged because of that. Then briefly about the kaput and the molding, we have already said that might influence our measurements of descent. It also gives us an indication of the progress of labor. We've said that in prolonged labor, the kaput might become quite big. We might also get the formation of quite big kaputs in the case where patients start bearing down early before the cervix is fully dilated. We can get quite a swelling of the fetal head because of the pressure on the cervix, as we've said. And we record that as 0 when there's no swelling, 1 plus when there's moderate swelling, 2 pluses when there's more swelling, 3 pluses when there's extreme kaput formation. Then molding is quite a very important aspect, and the last one that we're going to discuss here on the partograph regarding the progress of labor. And we measure this in also 1 pluses, 2 pluses, and 3 pluses. So 1 plus is when the sutures are not overlapping. You can easily feel the sutures and the bones are separated from each other. 1 plus is when the bones are touching each other. 2 pluses in where the bones are start overlapping each other, but you can still separate them easily with your finger when you're doing a vaginal examination. And 3 pluses is when the bones are overlapping and you can't separate them anymore. And what is very important is that don't just record on the partograph that there's molding. Also, this molding means something. When there's increased molding together with a high head, it's a sign of cephalic pelvic disproportion. So one needs to take that into consideration. Then the flexion of the fetal head is also very important in the progress of labor. And there's also on most of the partographs, there's not place to record the flexion of the fetal head, but I just want to add that onto this progress criteria for the progress of labor, because as I've said, it definitely plays an important role. When the head is well flexed, like in this case where the fetus almost sits with its chin on its chest, this diameter of the fetal head that presents is much smaller than in this case, for example, when there is no flexion or almost extension. Now, normally the shape of the pelvic floor, the muscles in the pelvis, makes that as the fetus moves through the pelvis, that the head is going into good flexion. Sometimes in abnormal positions of the fetal head, like in, for example, occipito-posterior positions, or when the brow presents, the fetal head is not in good flexion, and then it's a much bigger diameter that presents, and therefore labor will be much slower. Here you can just see an example of this total progress part of the partograph that has been filled in. Here, for example, the patient has been admitted, say, for example, she's in labor now, it's 10 o'clock. There's 4/5 of the presenting part still, of the head still above the pelvis. the cervical dilatation is 2 centimeters. The effacement, the cervix is 1 centimeter long. The presenting part's the vertex. The caput's nothing, no molding. This application is poor, and the station is -2. Then 4 hours later, because we do the observations, the progress of labor, we determine 4 hourly during the latent phase of labor. We see here now that the cervix is now 5 centimeters dilated. So the patient is now in the active phase of labor. So we have to remember, we have said we have to transfer all these observations to the active phase of labor. So we see the patient is 5 centimeters dilated. The head is 4/5, still 4/5 above the pelvic brim. The cervix is, the effacement is now better. It's now thin. The vertex is still the presenting part. There's no caput. There's no molding. There's still poor application, and the station is still -1. So the head is still above the ischial spines. 2 hours later, because now we do determine the progress 2 hourly during the active phase of labor, we see the patient has now progressed. The cervix is now 7 centimeters dilated, and it's normal because we've said that the cervix should dilate 2 centimeters per hour. The head has also, there's a little bit progress here. The head is now 3/5 above the pelvic brim. There's more effacement. The cervix is now fully effaced. The vertex is still the presenting part. Application is still poor, but there's also a little bit of progress of the station of the head. It's now at the ischial spines. And then 2 hours later, there was absolutely no progress. Cervix is still 7 centimeters dilated. And here you can now see it falls on the right side of the alert line. So we know now that there is now delay in the progress of labor. There's now prolonged labor. The head has there was no improvement in the engagement of the head. Is still 3/5 above the brim. These are all the same, except that we also now start getting caput succedaneum. Here, 2 hours later, there was still no progress. The head has gone down a little bit, but we see something very important here now. There's 2 pluses of caput, and there's 1 plus of molding, which tells us that this delay in progress of labor might be due to a cephalic pelvic disproportion. And that brings us to the end of lesson 2. Again, you have to complete your quiz, and then you can carry on to lesson 3. And I see you in lesson 3. Go well. I hope you have learned something.